Any thoughts on a person with MGUS with stable IgM protein, however, whose red blood cell count periodically goes below the minimum threshold, and that those red blood cells have very high volume and high iron content, for what that's worth.
So it's a hard question, and again, without all of your information in front of us. So when we think about your red blood cell count, your red blood cells are those that carry oxygen. So when we talk about someone being anemic, those are the cell lines that we're referring to. There are certain aspects of the red blood cells that help us understand what type of anemia it is when you're talking about the volume of the cell. Some cells are large volume, and that gives you a differential, meaning a list of possible conditions. It could be often B12 and folate deficiencies. Having a plasma cell disorder in and of itself can enlarge the cells. Certain medications, and I'm not familiar with your list of medications, can also cause macrocytosis. We have normal-sized anemia as well, and that can be from chronic disease or a variety of other things. And then when the cells are small, that's because there's not enough iron going around. And so that we typically see an iron deficiency, but there are some hereditary, like the thalassemias for people of Mediterranean lineage, who may have smaller red blood cells. So I couldn't, I think when someone has a plasma cell disorder, and this is general information for patients with precursor disease, one of the things that we look for when we think of the 4 distinguishing features of multiple myeloma, one of those is anemia. It is something we typically see in more advanced disease, where a significant portion of the bone marrow has been replaced with plasma cells. But when someone has an anemia with a precursor disease, it's certainly worth discussing with your physician and considering a bone marrow biopsy. General practice.
In the lines of therapy, do you still need a stem cell transplant right now before you would be eligible for CAR T?
No. Stem cell therapy is usually calculated as just that first line, like with or without transplant. It would also be called one line, so it doesn't add an extra line. It is not a requirement.
And it is also available for patients who are transplant ineligible. Let's be very clear about that. CAR T cell therapy, is determined by a patient's fitness, not his or her age. And so there may be patients who, when they underwent their initial myeloma therapy, who were, quote, transplant ineligible, but that does not preclude you from receiving CAR T cells.
I have a question about exercise, and I've heard different things about people who have myeloma or precursor conditions doing weight-bearing exercises. Like, can you use weights or should you use bands?
So patients with precursor disease should be able to do it at weights or bands and resistance exercises because you do not have any bone disease. So there's nothing, unless there was some other circumstance, inherently there would nothing that would preclude you from doing so. So symptomatic smoldering that had bone lesions would be multiple myeloma. Okay, so be very clear, a definition of a patient with smoldering myeloma is that you do not have lytic bone disease. What are lytic lesions? The word lytic means to lyse or destroy. So fundamentally, the types of lesions that we see in bone disease are where you have destruction of the bone. So intuitively, you have to be careful. It can be inside the bone or it can involve the cortex, that hard outer layer. So when you, and if you can do exercise, it depends on where any lytic lesion is located. Is it a weight-bearing area? And so that has to be done on a case-by-case, individual basis. And it also depends on the activity of your disease as well. And so, that is not a uniform answer. There are some patients, I have patients who lift weights with myeloma, but again, it is a case-by-case. So osteoporosis is another important factor, and so that's a little bit different, just so in terms of we're all speaking the same language. This is where you have it. Usually age-related, but can be disease-related multiple myeloma, thinning of the bones. Very often we see compression fractures as a result of both osteoporosis, but also compromised integrity of the bone as a result of the marrow being, the equilibrium being disrupted by the plasma cells. And so in those cases, 2 things. 1, most patients should be on bone-directed therapy, so either a bisphosphonate, such as zoledronic acid, or a monoclonal antibody such as denosumab. So that if you are not on a medication like that, you should have a conversation with your physician because that is an important part of myeloma therapy. Patients who have recovered from and are in good remission and have healed lesions may be able to go on to lift weights again and do weight-bearing activities. But if you have active disease and compromised lesions, that is usually contraindicated, meaning not allowed.
You mentioned that when you're on continued therapy, that it has the ability to suppress your immune system and affect your white blood counts. At what level of the white blood counts should a patient advocate for a Neutrogen shot?
Yeah, that's very depending on the regimen you're on and kind of where you are in this course. We may have different thresholds when somebody's first diagnosed because we're really trying to make sure they stay on schedule to try to get their disease under control and some of the symptoms reversed. However, if you're on maintenance therapy of 3-4 years in and periodically your white count or neutrophil count goes below 1,000, which is one of the cutoffs that we have, in many circumstances we would either hold therapy or dose reduce it because we don't want you out there, with significant impaired immunity because of a low white blood cell count. If you have a fever and your neutrophil count is less than 500, that's what we actually consider to be an emergency. Usually we have to go into the emergency room to get antibiotics and the workup done, right? So most people kind of fall somewhere between that 500 to 1,000 threshold, and that usually requires some dose adjustments on our part and periodically giving you white cell boosters. But that's not usually a good long-term solution. We don't want people on white cell boosters several times a week forever, right? So it's very depending on the scenario.
Thank you. I heard from Dr. Nadine supply chain issues several times, lack of centers for modifying T cells, and then lack of T cells, which may be able to be differentiated, right, into, where stem cells may be able to be differentiated into T cells. My wife had about 4 times the number you needed for her stem cell transplant. And I just wonder if you think that reserved stem cells may become a good source of T cells, which could be modified.
No, that's a great point. Definitely not there yet in terms of having the abilities to do that. Again, the stem cells that we collect are really they're different at a different stage, right? They're at a different point, whereas T cell collection is particularly for the lymphocytes. But I think that's an excellent point, and right now we don't have the capabilities of kind of converting one to the other.
Okay, I just had a quick question. I just want to understand that, is there no therapy for CAR T that is FDA approved? Is it all still pill?
But there are 2 approved.
That's what I thought, okay.
There are 2 different approved. Yep,
Okay.
Icell and Cilta-cel.
Okay.
So 2 different companies, 2 different products, yes.
Okay, and then they're moving on next year for more.
There are a number of, this is a crowded space, so there are a number of companies that have CAR T cells also studying that target BCMA, but then there are novel targets as well, and Dr. Nadine was talking about one that's not FDA approved that he's actively studying that may add to the armamentarium, but there are 2 approved.
Thank you. Clarify that.
While you do that, I realized during your presentation, let's see how many of those slides I failed myself. I don't think my plate looks as good as.
So there was actually a study that also showed that physicians are more likely to talk about it if they actually do it. And so that's part of it. If we work too much, we don't do it. So, at least we don't try and preach what we don't practice, right?
I was looking at that picture of somebody scrolling through their phone at night.
For the PROMISE study, and you talked about you have a family member, how close a family member do you look at? Are you talking just immediate family, parents, siblings, or cousins?
Yeah, so if you have one first-degree relative we can do the parent, sibling, child, you're eligible. If you have 2 or more second-degree relatives, which is one space removed, a cousin, you'd also be eligible. We often think that patients with first-degree relatives are at a slightly higher risk of developing multiple myeloma. They've got a twofold. There still is a risk for second-degree relatives. This goes for all hereditary cancers that we think have a hereditary link. The risk is probably a little bit less for relatives.
How often do you see both husband and wife who have multiple myeloma?
Or heard of it once. We see parents and children. Yeah, I have a mother-son combination. And I think this gets back a little bit to the point that Dr. Marinak was just making. Is it that we don't know, like in breast cancer, we know of the BRCA mutation, we don't know of a myeloma mutation. And so one of the questions that we ask ourselves is it a genetic modification that's passed along, or is it that you share an exposure? It's really most exposures take decades to manifest themselves, and so we don't know the answer to that.
I think another important thing when we're thinking about risk is just, this could also be a lightning strike occurrence, right? Where it's a chance occurrence. When we think about elevated risk, it's important to keep in mind that we're thinking of like an average risk for multiple myeloma is like 6 in 100,000. If you're thinking about double the risk, that's 12 in 100,000. It's still not dramatic. And when we think about risk factors, things that increase a person's likelihood of developing multiple myeloma and shared risk factors, it is, things like unhealthy lifestyle, exposure to certain chemicals that have been associated. These are significant risk factors, but it's important to keep into context. It's not, it doesn't necessarily mean that you are going to develop multiple myeloma if you have a family member that has it. It's not a destiny, and certain exposures will increase a person's risk anywhere between 10 and 50%, but it's important to keep in mind what that baseline risk is.
Hi, so one is in a clinical trial, smoking multiple myeloma, labs are up and down, but yet the heavy chain for IgE is through the roof. What in terms of research is, done for IgE myeloma, I guess, and you mentioned some clinical trials or new clinical trials that are available. How would that, what would be available for that?
That's a pretty rare subtype, and as Betsy mentioned before, all that's really alluding to is the type of protein your myeloma is making. So we don't really have trials for specific subtypes because it's not. We don't actually know if that's actually biologically different in a way, right? Now there are certain patterns we see with certain types of proteins that myeloma patients have. For example, patients with light chain only myeloma tend to have more kidney disease, etc. But so there may be some different symptoms that go with it. But right now there aren't any trials specific for the subtype. Okay. It's really kind of attacking the plasma cell, which is what we're doing, which should be the same.
Think of your subtype like hair color, and so everybody has a slightly different hair color or a slightly different subtype, but we treat it all. I think it's the same medicine.
Last one, lucky, huh? Jenny and doctors, thank you for being here today. Question for you. So you've got CAR-T, you got bispecifics. It's all wonderful, it's all terrific. I can't get it until I'm past 5. I'm almost dead. So I'm a huge patient advocate. What can I do to change that and get it moved up? I want to be able to live a lot longer, man.
No, I think your voice is really the most important, right? So I think kind of having forums like this, bringing it up, I think the FDA recognizes that, and I do think that they have to play this difficult sort of game where you have to wait for the trials to mature to make sure it's safe, right? And those are ongoing now. I think all of us were a bit surprised that it was in 5th line because the trials actually were 3 or 4 lines of therapy. So why they chose 5 for all these approvals is a bit puzzling to us because historically they just look at the trial inclusion criteria and kind of go with that. So it is a bit different in Europe, for example. People are able to get it a bit earlier, but I think your voice and any way you can raise it is going to be really important going forward. But hopefully we're not too far away from that. I think these trials are going very quickly. We already have some data. As I said, the CARVYKTI is going to be part of the FDA early next year. So the approval can come shortly after that in 2nd line, and then the bispecific trials are ongoing. But any forum that you have to raise that issue, I think this is a great one.